Um, well, we can go ahead and get started. Um, I think that, people will still be rolling in, and also the presentation will be recorded for everybody who may not get to make it to the live session, and those will be the place to access that will be emailed out to everyone along with CPEU certifications. Um, yeah, so I guess I just will introduce the topic today. Um, so the title of the presentation is Produce Prescriptions, a New Tool for Healthcare Providers. And this program offers the programs are offered by community-based organizations in cooperation with local healthcare providers. And the goal is to support patients with diet-related illness and limited financial means to purchase quality and a variety of fruits and vegetables which are needed for health and well-being. As a referring provider, registered dietitians can offer eligible patients vouchers for purchasing produce from local farms, markets, and retail stores. Health outcome assessment data is collected on patients. In addition, patients and many programs receive nutrition and cooking education to support the incorporation of fresh foods into their diet. In this talk, you'll hear from program managers in Tompkins County and the Southern Tier about local options as well as broader landscape in New York so that you can decide if becoming a referring provider is right for you or your practice office. And so I will turn it over to the speakers to introduce themselves.
Thank you so much. I'm going to share my screen while I introduce myself. Thank you for inviting us here today. We're very happy to see some familiar names and faces because really what we do is we run collaborative programs, and healthcare partners are such a huge part of what we're going to describe as our work and the work for us all to do collectively to mitigate chronic illness in our communities. So my name is Baz Perry. I am the Equitable Food Systems Coordinator at CCE Tompkins. What that means is that I run a number of programs that try to make sure that everyone in our community has access to the nutritional foods that they need. We run a farm to school program to bring fresh local foods into the school system. We also have a subsidized CSA program called Healthy Food for All that I'll introduce a little bit today, and the produce prescription program that I'll share in more detail. But we also have other collective endeavors at Cornell Cooperative Extension of Tompkins. The extension system, for those who are not familiar with it, started in agriculture. It really is about bringing the latest in research and best practices to the population so that farmers can grow the best quality and quantity of food and have thriving businesses, and so that we can all learn as adults about nutrition as well as human development through parenting classes and other education. I came to this work in a very roundabout way, but I have been in food systems basically my whole life. I started out as a child, I was really into Indiana Jones. And so what I ended up doing was always reading and dreaming about pre-industrial societies. And when you do that, it becomes very clear that the communities and societies that thrive are ones with a really great food system, right? With access to the resources they need to be healthy enough to fight wars and survive pandemics and get through other things that come their way. And so the need for a foundational food system and the need for every person in it to have the access, like an equitable distribution, is why I ended up studying agricultural economics at Cornell. I also continued to study religion and archaeology and think about sort of the long-term vision of like human health and well-being, how we treat each other, how we lift each other up. And so after college, I went to Harvard Divinity School, and I learned even more about how we sort of use community ethical actions, collective actions, to make sure that all of us are well looked after. After working in environmental work for a few years, I then got an information science degree, because in this world, in order to participate in collective action, in order to lift each other up in community work, we need to have access to the knowledge and information that we need. And so cooperative extension is a perfect place for me because it's all about bringing the best and latest research to our programming, to community development. What I would like to talk about today is the overall landscape that we work in, and what produce prescriptions are, like have been, and what they're becoming. And then I'll introduce our program a little bit briefly and turn it over to Erin Summerly to talk more extensively about her larger multi-county South Central New York FBRX program. So we operate in this idea or assumption that food is medicine. And I don't need to tell any RDs why we use that as sort of a foundational approach, right? And so we're addressing food insecurity and nutrition needs through this idea that we need interventions and services to respond to this link between nutrition and health that isn't there for every one of us. A produce prescription program is a little bit more of a narrower definition of how to have an intervention to fight chronic illness that is the cause of food insecurity. So here it shows the National Produce Prescription Collaborative came up with the definition. I'll just read it out to you. A medical treatment or preventative service for patients who are eligible due to diet-related health risks or conditions, food insecurity or other documented challenges to access nutritious foods, and are referred by a healthcare provider or health insurance plan. These prescriptions are fulfilled through food retail or a food bank in some circumstances, and enable patients to access healthy produce with no added fats, sugars, or salt at low or no cost to the patient. So I want to point out a couple key parts of this definition. One is that they are referred by a healthcare provider or insurance plan. And by nature, that assumes that they are under someone's care, right? And so they have a relationship with a healthcare system and are getting treatment for a diagnosed condition. The reason that we do this work, the reason this came about as a strategy is because it's very clear from the research that food insecurity causes chronic illness. There's a lot of research out there to prove this case, but I've just included 3 short statistics that we can all have at our disposal in case any of us end up in a conversation about why combating food insecurity is critical to our work in nutrition. So this chart here is from Canada, and it shows that food insecure patients have twice the risk of developing diabetes. A 2017 report from the USDA found food insecurity is associated with 10 of the costliest and most deadly preventable diseases in the country, including hypertension, diabetes, cancer, and stroke. And about 1/5 of all adult diseases from coronary heart disease, deaths from coronary heart disease are associated with low fruit intake and low vegetable intake. And so with this knowledge, we have created interventions to promote food access, right? Many of us are aware of the sort of federal programs that combat hunger. SNAP and WIC are probably the best known, as well as the school food system. So in this pyramid here, that's the basis that's available to everyone who is faced with food insecurity, faced with hunger. We have this broad range of programs available to people to try to make sure that they're getting enough calories, enough food week by week. There are also some elements of this that go beyond calories and make sure that people get enough nutrients specifically. So school food, for example, has very rigorous frameworks for what has to be included in each meal. And I would like to also just briefly go through a couple other publicly available interventions in New York, so that when you're working with someone who's food insecure, you can suggest it because it might be right for them in addition to a prescription produce program. So here I've listed SNAP and WIC and school food, again, which are available to anyone who's income eligible. But then we also have a program in New York called the Fresh Connect checks. They're given out to farmers markets that take SNAP or EBT, so that anyone who uses their SNAP card at the farmers market gets an additional $2 for every $5 they spend. And so this 40% subsidy encourages people to buy more fresh, high nutrient dense foods from local farms throughout the growing season. And they send them directly to veterans as well who request them. The fourth one that I'm going to highlight here briefly is the Farmers Market Nutrition Program. That's also run by the state of New York, and checks, they're in $5 increments up to $20 in a booklet. Those booklets are sent out to every WIC office in the state and every office of the aging or other registered sort of senior services agency in the state. And they distribute them to their clients usually in June or so. And then those can be spent at participating farmers markets, farm stands, or directly with farms that have enrolled. We also have out of Buffalo, New York, something called the Double Up Bucks program, which is similar to Fresh Connect checks in that participating farmers markets can take their EBT and double it rather than the 40% subsidy of Fresh Connect. It's very confusing having both programs in the same state. It comes about because the Double Up program was out of Michigan and has broadened to other states, and they just happened to come into New York that already had Fresh Connect running. So there's some confusion there you may find working with clients over what subsidies are available. The best thing for them to do is to talk with the farmers market at where they take EBT. And so those are all of the different interventions that we have that are accessible to anybody who's income eligible. Produce prescriptions, as you see on the pyramid, are available to a smaller subset of people who require additional intervention. And so produce prescriptions are available to those who have already been seen by a healthcare provider and diagnosed with a diet-related illness. Now, the reason that this is still prevention as well as treatment is that most of the folks who are getting referred have illnesses that can be mitigated, right? There is an element of recovery for some folks who are pre-diabetic, who are obese, who have hypertension and other ailments that require intervention, but can actually be healed through years of proper eating and lifestyle changes. So some of the folks in the produce prescription program are actively getting out of that range of having a diet-related illness. Others are sort of maintaining their health and keeping themselves from moving up the pyramid to needing a restricted diet with medically tailored meals. So we've seen how this has impacted some of our participants. And so nobody has to prove the case to myself or Erin or some of you who have worked with us. But what's really exciting is that nationally, there's a lot of peer-reviewed research happening that's helping to prove the case to everybody else out there. And so I just pulled, there are a couple studies out there that very clearly show that there's a great impact in having a produce prescription. So with diabetes, HbA1c levels can be dropped between 0.5 point to over 3 points. And remember, these programs aren't even that long. They tend to last 6 months to a year or so. Blood pressure decreases. There's often some weight loss, although that really requires a multifaceted approach. And so produce prescriptions would only be one of many factors leading to weight loss. It's also shown to dramatically reduce preterm birth by providing enough nutrient-dense foods for the mother. And it reduces depression. And I think we're just on the cusp of a lot of exciting research showing how important nutrition is to mental health. And personally, I would like to really expand produce prescriptions into the mental health realm. So that's something that's probably coming down the pipeline, not just for us locally, but also nationally. So the one thing that we've found through having about a decade of different pilot programs and different research studies being conducted is that we're starting to narrow in on the dosage or the amount of fresh fruits and vegetables that it takes to lower the incidence of disease or to lower the cost of the disease for patients. So this just shows a chart that if you increase one serving of fruits and vegetables per day, it decreases all-cause mortality by 5% and saves 30,000 lives across the US every year. And so that's a very small amount that's a very low intervention that has the potential to save lots of lives. This research has then started to sort of morph into program design, right? So if we know that a little bit of extra fruit and vegetables helps, more helps even more, right? That there's this sort of cumulative effect of dosage. Then what we can say is, how much money do we need to put into programs? What kind of subsidy do most food insecure participants require in order to move their dietary habits to a point where they're healing? So what this study showed is that a 30% subsidy on fruits and vegetables prevents 1.9 million cardiovascular events and saves $40 billion in healthcare costs. And so this is starting to get into the realm of putting it in terms that healthcare industry can understand, that the government can understand. And so there is a groundswell of support throughout the country to fund produce prescription programs and to make it integrated into Medicaid and other healthcare support systems. And that is happening in other states. So this map just briefly shows, I think, a conservative estimate of produce prescription programs that are currently happening in the US. They identify 94 programs, but they're very strict in what they use for the definition. So what I can tell you is, in New York, just professionally, I know of 6 programs, and only Erin's one from RHN is listed on the map. So in addition to her program and ours here in Tompkins, there are a number of small pilot programs run by SNAP-Ed nutrition educators. They tend to be housed at either cooperative extensions or regional food banks and pantries. And so what they are doing is offering vouchers to people who have been referred to nutrition education. And so the nutrition education happens first, and then the voucher is given out as people leave their classes. There is also a program in Rochester run by FoodLink. They have wonderful curbside markets that are full of fresh produce, and they have healthcare partners handing out vouchers to pregnant and nursing women, and I believe women with parents with small children as well, as an intervention to make sure that they're healthy with mothers and healthy babies. There is also a program in Buffalo, similar to ours, that is using a CSA model, which I'll describe in a few minutes, a farm share that is subsidized, so a lower cost for people, and they are tracking health outcomes for that. And then the 6th one I know about is the New York City Common Pantry has a Food MD program. And so in that case, people are getting referred to go to the food bank and pick up a specific bundle of nutrient-dense foods. So now that I've sort of described the lay of the land and defined produce prescription programs, I would like to just tell you a little bit about the one in Tompkins. This is going to be our 4th year here, and it grows and changes very rapidly with the support of the Cornell Master of Public Health program, where we have faculty helping to evaluate the program along the way, as well as a wonderful partnership with Hugo Center for Healthy Living, who helped found the first pilot program and is still our top referrer, as well as others within the Cayuga Health Partner System. And so this cooperative program that we're running allows us to have an approach that really encircles the patient with care, right? It sort of allows us to all get to know the patient in different ways, and through our conversations to then share knowledge about what services that patient needs to change their dietary habits. Our program came from a long-standing effort to provide subsidized CSA shares. So it's our 15th anniversary of our program called Healthy Food for All here in Tompkins. And about 300 households a year get a CSA share from a farm at half off or less. And so providing low-income families with access to food from nearby farms through a CSA is a proven strategy. And the CSA, for those who don't know, is a way of becoming a member of a farm and sort of purchasing a share of the harvest. And so a $500 to $600 deposit in the spring allows households to receive a bundle of produce for about 26 to 29 weeks, usually early June to late October, early November. And then some farms in our region have winter shares as well by using high tunnels and greenhouses. And that bundle of food can be appropriately sized for your household and has a variety. They almost always have leafy greens, both cooking and raw greens every week, as well as root crops. And then, fresh fruits and other things as they become available through the year. And this strategy of providing 26, 29 weeks, or even more with a winter share added, providing this to a food insecure family can really improve the amount of fruits and vegetables being eaten in the household. So even just with this sort of generally available subsidized CSA program, we had 98% reporting that they could then get an adequate amount of produce into their household for the first time. 93% saying that their household food security problems had been alleviated. And the majority of people also saying they'd improved their own diet and the diet of the children in the household as well. What makes the produce prescription so different is that instead of offering it to everybody, we were specifically looking for relationships with people who had diet-related illnesses and working with a healthcare provider, CCHL, and others in the community to refer those patients meant that we could reach the people who needed intervention most urgently. And so our approach to running a produce prescription program is to actively manage chronic diet-related disease through food access, but also with education. Education about cooking and about storing, purchasing and storing fresh produce, nutrition education provided by SNAP-Ed or FNEP educators using evidence-based nutrition education. And then also we've added some behavior support. So there's peer-to-peer support for participants to motivate one another through class dialogue and through a Facebook group. And we've also added some professional behavioral support. This last year, we piloted having 3 free health coaching sessions for each of our participants. And the ones who took us up on that found that very helpful to talk about why they're in this program and what motivates them to make long-term dietary changes. And then we use a lot of feedback from participants to constantly change the program. We reach out and talk with them on the phone regularly. We also have standard surveys that we use to know, are we running this program right? Are we communicating with you appropriately? Are we giving you everything that we possibly can that's in our control? And then the other thing I would say that's important about our approach is that it really is about forming a circle of care around these community members. And their RDs, their primary care physicians, everyone in the healthcare industry is a huge part of that. But we also get to know their family members, their neighbors who occasionally pick up their food with them, or they talk about cooking together, and recognizing that we're one part of a number of different influences on how someone changes their eating patterns. The other thing that we do is we really focus on local farmers for our food provision. Some of this is because we have relationships with our local farmers and we already had this system of providing CSAs in place. It was established, but also because it allows farmers to cultivate a relationship with the participants and vice versa. And that relationship of purchasing food directly from the farm, going to U-Pick if you're physically capable of heading out to the farm occasionally and getting in the hot sun, those kinds of relationships actually cultivate long-term commitment to these kinds of purchases. In addition to anything else that we could provide, the farmers are doing a huge service. And so what we've been doing is providing this CSA to folks who get an online referral from one of our healthcare providers. In 2020, because of COVID, we provided 100% home delivery. So we had 65 people getting delivery of their CSA during the summer, and then another 10 getting a fall and winter share. And we'll probably continue that for anyone who can't go to the farm. Although if they are able to get there, we really do, again, value that relationship. We also now have live as well as recorded online learning options. We have a cooking hotline open a couple hours each week where people can call and say, what is this thing that showed up in my box? How do I cook it? We also have recordings on our website and handouts, and a Facebook group, again, for discussion as well as communicating resources. And we really try to talk with them every week. We send out recipes and motivation and call them on the phone and answer their calls just to stay in regular communication. And so again, you can sort of hear that what we're trying to do is establish sort of a social system so that patients really and participants really feel like we are invested in their health and well-being, and trying to encourage them to be invested and to value themselves as well. So the last thing I'll say is that we're very excited that we're going to be merging our program with Rural Health Network's program. Erin is about to introduce herself and describe that program to you. And what's really exciting is that it means in Tompkins, in addition to having the CSA model available to participants, they will also be able to use her voucher or coupon-based model and shop independently on off hours or different schedules for specific produce items that suit their cultural needs and their personal preferences and their skill set in cooking. And so based on participant feedback, we're super excited to be joining with Rural Health Network and providing that sort of diverse choice that gives people the dignity to change and make these dietary changes at their own pace and in their own ways. So with that, I will welcome Erin to introduce herself.
Great, thank you, Baz, and hi everyone. Thank you for joining this afternoon. I know at least one of our community partners and FURX program providers is on the call. I think if you're still there, Donna, feel free to jump in when we get to Q&A if you have anything else to add as someone who's doing this work on the ground. But as Baz said, my name is Erin Summerly. I work for a nonprofit organization based in Binghamton, the Rural Health Network of South Central New York. We're based in Binghamton, but we do cover an 8-county region. Certain programs have different sort of service areas, but that's our general scope. And the organization as a whole, just like cooperative extensions do a whole lot of things, our organization touches on a lot of different aspects of health and well-being with the focus on rural people and communities. My particular area of work, again, similar with Baz, is focused on regional food system development and really helping to bridge food access and, while also helping to support local agriculture, working with institutions. We also help support farm to school programs and a number of other initiatives in addition to our fruit and vegetable prescription work. You can go to the next slide, Baz. So there are a lot of similarities with the program you just heard about in Tompkins County, which is of course why it makes a good fit for bringing our programs together more intentionally. But just for a little bit of background, we started as a pilot in 2017, I guess was our first year of running a pilot fruit and vegetable prescription program, or FURX. You'll see that acronym used sometimes. I might slip up and use the acronym, but FURX is fruit and vegetable prescription program. We started that 2017 was our first year. So we're now going into our 5th year of offering the program. And over time, it has expanded quite a bit. So we have room for around 400 participants this current season. And I should also add our program not including the, future work in Tompkins County. Our program is Broome, Tioga, and a small part of Delaware County, mostly centered around the Walton area, where we currently offer the program. Back in our first year, our focus, we piloted working only with registered dietitians. We worked with a practice based with the UHS hospital system, and then also with the Lourdes hospital system. Just two primary care practices running it through a registered dietitian that covered both of those. Over time, we found out that for some locations, it works great and they have the capacity where, RDs are covering a lot of their primary care sites. Other hospital systems have less RD capacity. And so we opened it up in our program. We have RDs, we have wellness coordinators, physician assistants, residents, and probably a few other provider types that I'm forgetting at the moment. So a range of different folks who are offering the program based on what fits best with just, the staffing at that clinic, and then people's capacity and workflows. And then we also have some community-based providers. So this past year, we started working with one of our county office for aging, who has a registered dietitian who is offering the program. And then within Rural Health Network, we also have a community health worker program, and they are a part of the fruit and vegetable prescription program and our model as well. As Baz mentioned, we do have a voucher-based program. So participants receive voucher booklets. Actually, it's handy that I always have these next to me at my desk. So we have, it looks like a little coupon booklet, and folks get, the vouchers that they can then spend at a number of different shopping sites. And if you want to click to the next slide, Baz. So each of these booklets generally contains $120 worth of $5 coupons, and individuals, once they're enrolled, they'll go back at about 2-month intervals to see their provider, get support, just some general educational support, as well as, how is it going? Are these sites working for you? Did they have, food that you want to buy? Do you need help with transportation? That type of support. And then they'll get another set of their voucher booklets and can go spend those. We have, I believe there are about 17 different locations where participants can shop right now. So that ranges from farmers markets, farm stores, a few CSA programs that are similar to the program that Baz was speaking about that serves Tompkins County. And then we also have several grocery store partners as well. So we did start out with entirely sort of local direct farm type of sources. And over time, just in an effort to try to broaden, the hours that our shopping sites were open and just create as much choice, we've, brought on some other partners that aren't 100% sourcing local food. And particularly, especially in Delaware County, which is very rural, but obviously Tioga County, parts of Broome County, the options can be limited in certain communities. So we are just trying to create as many shopping options, right in the community where people are living. And then some of you on the call might be familiar, but within the Rural Health Network, we also have a transportation program called Get There. And fortunately, they are able to help many of our FERX participants who have transportation barriers access rides to shopping sites, but then also work on home delivery if that's something that a particular participant needs. And We also are increasingly, we've offered some of our own sort of educational programming in the past, but we're increasingly trying to work with the SNAP Ed program and just some of the existing community resources that are out there to have our providers make referrals to those programs and get participants in the program enrolled in those. But we do offer from the Rural Health Network chronic disease self-management program. So that's just another tool that, is available for our program participants. And you can go to the next slide, Beth. And just lastly, just some of the program materials that participants receive. Again, another picture of voucher, shopping guides, which is just a little pamphlet. We started to create a much longer sort of vendor directory with a lot of information. People, we found after the first few years, participants would come or have a conversation, 5 months into the program with their provider, that they hadn't actually spent any of their vouchers because they'd never been to a farmer's market before and they were intimidated, or they didn't know what it was going to look like. They didn't know what to do when they got there. Could they park? So in this larger, it's the one on the left, in this larger directory that we have, it has like a lot of information, just more details on kind of what you can expect from every site to help ease some of those concerns. I think I'll stop there and hand it back over to you, Beth.
Thank you, Erin. I'll have to give Lara's apologies. Lara could not join us today. She has some personal things going on. And so I'm going to present a little bit more on ways for you to all get involved if you're not currently already involved in the prescription produce programs in this area. And then if there are any questions that either Erin or I can't answer, or other people on the line can't answer. Oh, I see Lara's face. Hi, Lara. Oh, you made it. Okay, well, just to let you get settled, how about I'll just run through some of this, and then you can add anything you want to, just give you a little breather after a big day. So obviously, becoming a referring provider is one of the most immediate ways that you can participate in a prescription produce program. But I wanted to also point out that because this is a new movement, a new intervention that we're all trying to broaden for our community and for others, I think it's really great if any of you can advocate at your offices or with your colleagues for the importance of these types of programs, especially as we try to integrate further with the healthcare system and encourage healthcare insurers to cover produce prescriptions and give financial stability to these kinds of interventions. It's always very important for RDs to speak up about what they see in their clinical practice as the usefulness of these kinds of programs. I think also, even whether or not you work specifically with RHN and myself, familiarizing yourself with the kinds of nutrition incentives in your region and the accessible produce options available is really helpful for your clients. I mentioned some of those different farmers market checks. Your local cooperative extension office is a great place to turn to if you're curious about what farmers markets are available or who has checks to hand out, et cetera, just to try to have that professional development of knowing how do people access the food that they need in addition to a food pantry and SNAP or WIC. There's also always room to volunteer your time at a local free clinic for individuals who don't have health insurance and the means to pay for an RD. As incidents of chronic disease increase, and it's particularly borne by people with low income, there aren't enough resources to give everybody the kind of advice that they need from people with your knowledge and experience. And then the last thing I'll say is it's sort of a slow wish list item, but we are trying to create sort of a statewide a group of people to start to lobby for food as medicine, to lobby the Medicaid office to try to reimburse and cover produce prescriptions, and work with the governor's office and state legislature to inform them about the need for these kinds of nutrition interventions. So with that, Lara, do you have anything that you would like to add?
Hi, everybody, and I'm very sorry that I'm coming to you late and I missed the bulk of Baz and Erin's presentation. I'm very fortunate to be able to work with Erin and Baz and actually others on this call. I'm really happy to see Dr. Sandage here. And I think you offered a great summary of ways for registered dietitians to get involved. I think the only thing that I would add to that list is being able to have conversations with providers about what to look for when identifying appropriate patients, patients that would be a good fit for the produce prescription program. And that is so that the patients are being set up for success, the patients that are most likely to remain in the program are set up for success so that they can actually contribute to the learning that happens when you have group learning experiences. There's richer conversation when there's the opportunity for peer-to-peer learning. And then you're also helping to ensure the longevity of the program, because then you have more people who are successful with the program and are able to do word of mouth recommendations. So I would say, Dr. Sandage and Krista and folks from the Center, Huga Center for Healthy Living have done a really good job of identifying the patients that they think would have the greatest chance of success and staying in the program. So having those conversations, I think, are really important. And I don't know, I don't want to put Dr. Sandage on the spot here, but I think she could speak to that very well.
Yeah, no, happy to. This was a wonderful presentation, and so nice to hear in more detail from the Rural Health Network as well, which is very exciting to see that coming on board. Yeah, we over the past the three programs we completed, yeah, learning the importance of setting up the patient's expectations, because we didn't really know at first. I mean, you tell someone, hey, would you like, access to some, free food, and then sort of explaining, how it works. And again, having them know that it's not, to really get the most out of it, it's not totally a passive experience, that they'll be encouraged to not only, get the produce, but use the produce. And I think it was interesting, the issue of finding out that patients get the book of vouchers and never use them. So, we learned initially that, there might be issues with transportation and trying to just get to the food, since we were doing it through a CSA approach. So sort of troubleshooting that. But then, what is their living situation like in terms of what sort of resources they have to cook with? Not just the knowledge, but do they have, just basic equipment, those sorts of things. So it's like layers of an onion, trying to learn all this. But again, really trying to get them to engage. And before COVID hit, our real intention was to create more of a group, or I should say Baz's intention and good efforts was to create more of a group effort. And we sort of required them to attend some sessions that were informational on the front end, again, to sort of let them know, okay, this is how this will probably work the best. And then some instruction, that sort of thing built in. So hopefully we'll be, moving back to that as we move past the pandemic and the coming whatever amount of time. But yeah, it's as is the case with a lot of chronic disease, there are just a number of factors that the patients are struggling with. And so, whereas for someone in good health and good mobility and good mental health and that sort of thing, just providing them with fruit and vegetable, and they have a background that allows them to know how to make use of it, so on and so forth, is one thing. The other thing is that a lifetime of challenges makes it so that you don't want this to be another, challenge that they feel like they don't succeed at. So setting them up for success, as Lara put it, I think is key. So anyway, this is so exciting to see this moving. And if I'm not already on your lobbying list, Baz, put me in the loop on that. So very exciting.
Okay, well, I guess we can open it up to if anybody has any questions, but thank you so much for that wonderful presentation. That was so great.
Thank you for having us. I'm going to put one thing in the chat too for anybody who wants to learn more about produce prescriptions. There was just a wonderful report that came out from the Center for Health Policy at Harvard. And a lot of sort of my early presentation was pulled from that most recent data that they've collected. So I'll just put that link in the chat for anyone who wants to read more about it.
I guess I can ask a question that I was wondering. So do y'all think that with fruit and vegetable prescription programs, do you think that it's something that needs to be implemented more on a local basis, or is this something that our federal government can take up to try to offer like nationwide, or do you not think that that would work or be palatable? I just, because obviously they've been proving their effectiveness very well, and especially something that appeals to me on more of a national level was something that Baz talked about towards the beginning about the 30% reduction in subsidy of fruits and vegetables led to $40 billion in savings of healthcare costs. And so do you think that that's something that could or would or should play out at the national level, or is it something that's more better implemented at the local level?
I can start to answer, but then welcome everyone else to hop in. So one thing that is happening at the federal level is grant money. Actually, in 2 days, Aaron and I will submit for a grant to bring $500,000 into our region to expand this program. And so it's the nutrition incentive grants that they're offering from the USDA have really launched and expanded these programs by millions of dollars over the last couple of years. And I do expect that with the kind of research results they're seeing, that will continue to expand and alongside the SNAP expansions that we're seeing under the current administration. But the strategy has been to allocate those grants to local organizations that are already embedded in the community, because a lot of the work really is about that collaborative relationship between healthcare, community-based organizations, farmers, and nutrition educators. And so doing that when you're an outsider, at a regional level, just isn't as effective or as quick to implement. So I think that they've got the right approach there of making sure that each region has some sort of local coverage. And I think especially because it really is focused on direct farm food rather than large industrial supply chains of food, it also is going to have to vary region by region based on the growing season, the amount of agriculture happening in that area, right? Like we have a lot of diversified farms in New York, not the case, right, in sort of breadbasket areas with just acres and acres of commodity crops. So it's going to have to be tailored to the local environment.
Yeah, I would, I fully support that. I think, if there's more federal funding directed towards these programs, that's fantastic, and it's needed. But I would put sort of a big asterisk next to that that it doesn't take away from, regional variation and just being able to accommodate local needs. And even just in this funding that, Baz was mentioning that we're applying for, it does sometimes with the private funding or being able to do different contracts or pilots with some of our insurers, it just allows us to be just more flexible rather than having to fit into a very like narrow sort of box of how education has to look, or where, you know, certain things, we just have more flexibility when the funding is coming from a more local source. But I also just think on the insurance side, there's a lot that can happen there too, just in terms of the type of waivers that can be, you know, set by the federal government and then implemented at the state level in terms of what's a reimbursable, you know, service or not, or what's allowed under different insurance plans that the federal government does have an impact on. I think there's, you know, from a more regulatory standpoint, there's more that can, and I think is, you know, moving in that direction at the federal level, not just from a, you know, grant funding standpoint.
Thank you. Does anyone else have any questions?
This is Donna Bates from the Broome County Office for Aging, and I just wanted to comment in relation. One, I comment in appreciation of our work with the Rural Health Network of South Central New York, and Erin and her team have been really a great crew to work with on this program, and last year was our first year with that, and they offered a lot of support, and I think people, the people that I worked with really benefited. I worked with those that were referred for nutrition counseling and to our agency. So I did want to comment, Baz, on your remark about the mental health aspect of this, and it was a surprise to me. I had a couple of the people that we worked with comment how this helped them, especially through COVID, through depression, that they were planning on, you know, like planning on preserving, you know, we're thinking of, it gave them something to think about because they had the fruits and vegetables and sometimes extra. And so they were two people commented about, oh, this gave them something to think about and knowing that it was helping their health. So I just wanted to add to that comment regarding that. So thank you.
Well, thank you so much for sharing that, Donna. I think it is, you know, we often look at the big statistics and the sort of aggregate population impact that we're having. But when you work specifically with an individual whose life is being changed, it is so powerful. And it makes me feel like it's all worth it, even if just one person is really getting something out of it. I had the same feeling last year. Actually, we had our orientation classes during April, right? We'd all just been at home for a few weeks. And it was wonderful to have 35 people gather on Zoom and for us to talk about having a growth mindset, right? And setting our own personal health goals and saying, okay, like here we are in difficult circumstances. Can we have something positive that happens during this season of our lives? And to say that we're going to do it together, right? And I think people really engaged, even though it was on Zoom and it was a little awkward trying to transition from live classes online and everything. People really put a lot into it. And I think you're right. I think it was a wonderful sort of way to say that this time is not a lost time in our lives, that we're still able to accomplish something.
Does anyone else have any questions?
I don't have a question, but I wanted to add a couple more thoughts. One is related to the power of bringing people together around food, and how I think the Produce Prescription Program, or FVRX, is an opportunity to blend programs that perhaps have had challenges with recruitment and retention, So that, let's say, for example, you have a diabetes prevention program or a diabetes self-management education program. Sometimes having something connected to that related to food preparation and food access, if there are opportunities to sort of pair those things together, I think they would really be mutually enforcing and strengthening. So that's one thought. And then one other thought related to the funding. I was thinking about the fact that across New York State and really across the country, there's all these different funding mechanisms, and each funder requires something slightly different regarding outcomes for reporting. And while having different funding helps us keep our programs going, and it's important for us to have diversified funding, one of the challenges that it presents is that each program is collecting slightly different information. And I think one of the goals, and hopefully I'm not speaking out of place here, Baz and Erin, is to be able to eventually get to a place where we're all collecting very similar information so that we have more power in pooling together outcomes to demonstrate the value of what we're doing.
Okay, well, if nobody else has any more questions, we can end there. So thank you again to all three of our speakers. I thought they did a wonderful job with the presentation, and thank you all for taking time to put this together and to come present it for our members and for practitioners all over the state. Yeah, and again, the recording and the CPEU certification will be sent out hopefully by the end of the week. So if you guys have any questions, feel free to email the contacts provided in the Eventbrite. Thanks, y'all.
Thank you so much.